The next thing we can do to help open our patient's airway is suctioning. So the reason that we use suction is to remove blood, vomit, other liquids, and food particles from the airway. This may not, however, be adequate for removing large, solid objects like teeth or foreign bodies like a marble or a toy or a coin or candy, or any type of food. Suctioning should be performed immediately if you hear gurgling with spontaneous or artificial ventilation. So anytime you hear gurgling, the first thing you should think is suction. Now gurgling, imagine you're gargling salt water, that kind of gurgly noise where it's bubbles going through liquid in your throat. That is what gurgling is. And if you hear that, you got to get that liquid, that fluid out, whatever it is. So use suction. So how do we do it? Well, we have suction devices. There are some that are mounted in the ambulance that are attached to a truck-based suction, so you can't take them with you. There are some that are portable, like this one over here. There are electrical ones, like this one, and the hand-operated ones. These tend to be less effective, but that doesn't mean that they're ineffective. They do work a little bit. They just require a lot of work on your part to make them work. You have to squeeze something. So here's the thing, they should generate at least 300 millimeters of mercury. That's what this is, and that's a measure of pressure. So they should generate a vacuum of at least 300 millimeters of mercury. Of course, you don't want to forget to charge your unit. These are battery powered, so you need to keep it plugged in so that it charges. There are some additional suctioning devices. So there's a rigid suction catheter, and this is used to suction the mouth and oropharynx of an unresponsive patient. So you do want to measure before insertion, and we'll talk in class about how to do it. Take caution not to touch the back of the airway. So basically when you're reaching back and sticking this thing in somebody's mouth, you want to make sure that this tip doesn't actually bump the very back of the airway. Particularly in infants and children, because this can actually cause the heart rate to drop. I'm not really going to talk too much about the mechanism. It's a little bit in detail, so if you're interested in knowing why, I can explain it, but we're not going to do that in this lecture. There are also soft suction catheters, and you can kind of see it here. This is a really up-close picture. This is a tracheostomy tube, so there's actually, this is somebody's neck. Right here, the skin here, and there's a cut in their neck that has allowed a doctor to insert a tube into the trachea. So these are going to be kind of your sick patients or patients with airway issues who have these outside of the hospital. But they're not uncommon. So you're going to use this soft suction catheter here to suction that. It should only be inserted as far as the base of the tongue. So if you are using this in somebody's mouth, then as far as the base of the tongue, or the end of the tracheostomy tube. So this mentions up here, it's also useful for suctioning the nasopharynx. Some days I wish I had one of these at home and I could just, like especially during allergy season, I wish I had one of these at home so I could just suction out all of the goop in my nose and my sinuses from allergies. But that's basically the idea behind this, is that you can suction the nose and kind of the back part of the throat, or you can use it to suction the trach tubes. So how do we actually suction? Well, you have to turn on the unit if it's electric. You have to attach a catheter. Then you want to measure the catheter. You're going to take and insert the catheter into the oral cavity without suction, and this is kind of a big thing. So put it in there without sucking. The reason for this is that if you have suction, it's real easy for the tongue, or like the sides of the cheeks, any of the soft tissues in there will actually get attached to that suction, and then you'll have to get the suction catheter detached from that and then put it back in. So you only insert it to the base of the tongue. So basically you don't want to stick it in farther than you can see. Apply suction, move the catheter from side to side. In adults, you want to suction no longer than 15 seconds. Pay attention to these numbers. 15 seconds in adults, 10 seconds in children, and 5 seconds in infants. You then want to rinse the catheter with saline or water to prevent some sort of obstruction. So by rinsing, we really mean suck up. some water. Now I'm going to talk about oral airways. So you heard me talking about airway adjuncts. Adjuncts. An adjunct is just something that we use to help ourselves out or to help our patient out, I guess. An adjunct, so an oral airway is an airway adjunct. And this is one that is used on unresponsive patients without a gag reflex. And this is key, without a gag reflex. So look at this thing. This is the only part of it that actually sticks out of your mouth, is this little part here. The rest of it goes back, and the idea is that the tongue is held up. So there's the patient's tongue. The tongue is held up by this piece of plastic. This goes all the way in the back of their throat. If the patient has a gag reflex, they're going to choke and gag and probably puke on you if you try and put it in. So patients without a gag reflex. Like I mentioned, the idea here is that it helps hold the tongue away from the back of the throat. The tongue is one of the most common airway obstructions, and we need to do something to make sure that the tongue stays off of the back of the throat. So the technique for this, number one, you have to measure. So you measure from the corner of the earlobe, the corner of the mouth, so right here, either to the earlobe or to the angle of the jaw. So it kind of depends on which way you go. You'll end up with the same size either way. You're going to open the patient's mouth. You're going to, in adults, insert with the tip of it, so this is the tip of it facing the roof of the patient's mouth, and advance until resistance is encountered. You're going to flip it upside down, so 180 degrees, until the flange, which is this part, comes to rest on the patient's teeth. In infants and children, you want to use a tongue depressor to lift the tongue, so you basically do like the doctor does, and push the tongue down or lift it, depending on your angle of view, I guess. And then insert the oral airway facing right side up. So there's no turning with the oral airway, and the reason for this is just because you can damage the soft palate of kiddos. They have really tender tissues back there, and so we don't want to damage the soft palate. Adults, you know, the tissues aren't quite so delicate anymore. So who gets an oral airway? Well, any unresponsive apneic patient. So remember, apneic is not breathing. Any unresponsive apneic patient with or without trauma. And any apneic patient that's being ventilated with a BVM. And no gag reflex. So if you are ventilating a patient with a BVM, try putting an oral airway in.